Well, good evening, everyone, and welcome to Daleswood Health Talks. Tonight, we are covering arthritis, and we're very lucky to be joined by a consultant rheumatologist, Dr. Mary Guyard, who's joining us from Spire Parkway. So, aim of the Daleswood Health Talks, for those of you who have been, you already know what this is all about. Our aim at Daleswood is to change the dynamic of healthcare. I'm a GP. I've been a GP now for over 10 years in Solihull, and I realised that actually I was getting further and further away from my patients than closer to them, the harder I was working within the NHS, and I didn't like that. So the aim of Daleswood Health is to go very much back to the traditional relationship that you had with your family doctor, where they are your doctor, they're the only person you see, and they will look after you day or night, weekday, weekends, apart from when I'm on holiday. It is a husband and wife GP practice. So my wife, Alison, is also a local Solihull GP, and together we have set up what we hope will be a much nicer way of working and a much nicer environment for patients to access healthcare. Part of that is breaking down the barriers, allowing you much closer relationship with a doctor, and this is part of it. I'm a normal human being and like talking to people socially and professionally. And tonight is about breaking down that barrier completely, so you can ask me questions, Mary questions, and if you have issues when you've left the GP practice and you didn't know what was going on or what the diagnosis was, and you have lots of questions afterwards, it's very hard to get back in. We're completely opposite. We want you to come back in. We want to answer your questions, and this is part of that process. I also want you to...
Can we stay for you more than 10 minutes?
Oh, absolutely. Absolutely. As long as you like. Until the next person arrives, of course. But yes, you can say if you want to stay for 10, 20. We don't actually have a 10-minute option because we don't think that's reasonable at all. The shortest period of time is 20 minutes. So the other reason for these talks is to try and make you expert patients. If you have a problem, I want you to know as much about that as possible. I want you to know even more than me, because ultimately you're the one that's truly motivated to understand what your problem is. But equally, as your doctor, I want to know even more than you. So it's always a bit of a challenge. I want to know more about your health than you know about your health and the conditions that you have, and I want to try and inform you as much as possible. So I would really like you to become expert patients, to know as much, if not more, about the condition that you have than I do. And I've already said it's all about engaging with us. It's all about breaking down that barrier between doctors, because sometimes it is quite intimidating when you go in. You're thinking, oh gosh, I hope I'm not wasting their time, and they haven't got much of it, and what about the next person? And I feel so sorry that I've kept him for 15 minutes. That's not what healthcare should be about at all. It should be about giving you the opportunity to express your problems and to understand what it is that brought you into the room in the first place. So that's what we're all about at Daleswood Health. So I will introduce you now to Mary. As I said, she's joined us from Spire Parkway, and she is a consultant rheumatologist.
Hello, good evening. It's nice to see you all today. Thank you very much for coming. So my name's Mary Gedd. I'm one of the consultant rheumatologists. I work over at the Spire and also have my NHS practice at Heartlands and Solihull Hospital locally. I'm also interested in training. So I currently am a member of the West Midlands Training Committee, which coordinates training and plans training for current registrars in the training scheme. I'm also interested in research. I did a Master's in Clinical Research as part of my training, and I'm involved in several clinical trials as part of my NHS work as well. And again, it's all about the drive to make sure that patients are educated as much as possible, and that we're always doing evidence-based medicine and finding out what the best current evidence is, really.
Thank you, Mary. So we'll dig into arthritis. It's an incredibly broad topic. Just putting the word down, arthritis, kind of filled me with fear, because there are so many different reasons why you can develop arthritis. The one I think we're all very familiar with is osteoarthritis, wear and tear. But ultimately, arthritis is a pretty broad description. It is pain, swelling, and stiffness in a joint. It doesn't define what the cause of that is. That's just what arthritis is. And as doctors, we'd like to try and categorize things. It makes us easier to work out which specialty it belongs to or what the cause is. And so we try and break it down either into mechanical and inflammatory, or primary or secondary. And by that, mechanical is the wear and tear. Inflammatory is another reason why the joint has become inflamed other than wear and tear. Primary is a direct issue within the joint. And secondary is something else that's causing a problem within the joint, another disease or another condition that's affecting your joints. And I've just put a quick picture up on here because arthritis is pain, swelling, and stiffness, but your joint comprises of more than just two bones coming together. There's quite a lot going on within a joint. And this diagram here shows two joints. This is a typical synovial joint. That's one with a bit of oil in it. You have a capsule, which is often formed by the ligaments that come around the side, and that's sort of a bag within which the joint sits. And you then have this packing, this synovium, which is fluid often, and that's what can make your joint big and swollen at times and can become suddenly very swollen because all of that fluid increases. We then have the bone, the ends of the bone, which is covered in a nice, smooth, slightly spongy material called cartilage. And then you have a film of lubricating fluid which kind of runs over that, and that's the synovial fluid. And the aim of that is to make it as smooth and as glossy and as perfect as it can possibly be, so that there's as little friction within that joint as possible. So that is a joint. So what's all the fuss about? Well, there's some pretty startling statistics when it comes to arthritis. 1 in 6 in the UK, about 10 million people in the UK right now suffer with arthritis of one form or another. It is the most common cause of disability. So there's lots of different reasons why people can be disabled, but arthritis is the most common by a long way. It's responsible for 25 million work days lost a year in the UK, equivalent to £3.4 billion of lost revenue through sick days. And that's just in the working population. The cost to the NHS is even higher than that, at 10.2 billion. Those figures are a couple of years old now, so it will be higher. And that's what arthritis costs the NHS every year. And really, in terms of how we can prevent or reduce the progression of arthritis, it's very much about addressing the problem as early as possible, because if we do, we can significantly alter the course and the progression of that condition. And really that's the most important thing. And primary prevention with arthritis is so important, but once you've got it, you can prolong or make the condition progress much slower if you do the right things. And in part tonight, I hope to kind of inform you about what you can do to help. So that puts it into context. It's a really common, really serious issue that impacts on the nation's health quite significantly. We talked about different ways of trying to work out what sort of arthritis you might have. And this table's quite a nice, easy one to look at. We talked about inflammatory and mechanical. And as a doctor, the first thing I'm going to do when you come into the room, apart from notice your limp or notice the swollen joint, is start asking you about what's been going on. And all of the questions here, or all of the things on here, apart from the sort of examination, are key to working out whether this is inflammatory or whether this is mechanical. And it makes a difference in terms of the treatment and the prognosis. So from an inflammatory point of view, whenever we've got an arthritis, we often feel pretty stiff in the morning. But the inflammatory arthritis tends to leave you stiff for very much longer. Even in my 40s, I still struggle in the mornings and am stiff from one thing or another. And that is usually transient. For me, it lasts about 10, 15 minutes. For others, it can be about an hour. But osteoarthritis tends to give you a stiffness in the morning when you haven't been using your joints for a shorter period of time. The time at which you get the pain as well is also important. When you've been up and about and you've been using your joints, if they're worn out, the sort of more you've used them, the more issues you're going to have. So you tend to get the peak discomfort in mechanical arthritis, the wear and tear, after you've been using it a lot. Whereas with the inflammatory arthritis, if you've been still for a long period of time, you tend to get much more pain, which fits with the fact that you get prolonged morning stiffness with the inflammatory arthritis. And then there's some subtle differences which really come down to the doctor examining you and having a look at your joint as to whether it's swollen, whether it's hot, whether it creaks. As you can imagine, if something's worn out, that nice glossy glass surface has been lost and you're left with the rough ends of the bone. And that's a pretty grating experience. It makes me judder every time it happens, and I'm astonished at how severe it can be in some people with how sometimes almost no pain at all, which is astonishing. But equally, it can be incredibly painful when you have that crepitus is the medical term, but that crunching and grinding in other sort of lay terms. So osteoarthritis, this is the main one really, and I suspect most of you here this evening are here about osteoarthritis. It tends to happen in your late 40s, and it is actually more common in women than in men. The cartilage, that nice sort of glossy surface, the end of the bone, starts to thin. And you can see in this diagram here, there's sort of a normal side and an abnormal side. The cartilage starts to thin, and that's the sort of immediate cushion, if you like, that takes some of the shock. With that, you start to get inflammation in the bone, and you start to get new bone forming, and you get those sort of knobbly knees or the big gnarly joints that you see. And that's a sign of arthritis, where the bone is just starting to grow out at the sides of the joint. And those are called osteophytes. It tends to be quite slow. It slowly comes on. You might have a little flare up for a while, for a few weeks, and then it settles down. And that cycle, just the length of time it takes to settle down is longer, and the gaps in between become shorter, until eventually it's a sort of constant ache and a constant pain. But you'll usually get a few warning shots across your bowel before it develops into a constant pain. There's some really, really useful resources that I'd encourage you to go and have a look at. And one that I find very useful, and they're very supportive of GPs, is Arthritis Research UK. Their website is versusarthritis.org. But if you just put in Arthritis Research UK, it's a very good website. They have so much useful information there about what exercises to do, what diets to try, what things to avoid, and well worth a look. A huge repository of information there, and one that I use quite regularly. In fact, I'd say half of the patient information leaflets I give out for people with back pain or people with arthritis or gout are produced by Arthritis Research UK. And
sorry to interrupt, but I'd strongly agree. Certainly in secondary care, we give out these leaflets a lot, and it's an excellent source of reliable information, because the problem with Dr. Google is that you can come up with all sorts, whereas it's very good. It's written by medical specialists, written by consultants and orthopaedic surgeons. So they're medically accurate, and they're an excellent source of information. They've got exercises to practice and all sorts of things like that. So I well recommend it.
Yep. Another one is patient.co.uk. They actually reference Arthritis UK. They've got videos if you want to see how to do things and all sorts of different things there. You don't look at this slide. There's a lot of information on it, but it's really, this is pulled straight off NICE's guidance for arthritis. So NICE is the National Institute of Clinical Excellence, and it's really to highlight the fact that arthritis affects us in so many different ways. And as a GP, my aim is to take a holistic approach, to look not just at the fact that you've limped in and you're saying you've got pain, but the impact that has on your wider health and your wider social circumstances as well. Because when someone becomes disabled, that has a significant impact on what they're able to do at home, whether they're a carer, whether they're co-carers, and certainly with arthritis, which affects you as you get older, a holistic approach is really, really important. And as you can see, it's about the social, the occupational, the moods, the quality of your sleep, your social network. My grandfather, who's now in his mid-90s, had a knee replacement in his late 70s, early 80s. I was like, why are you doing that? Well, all my buddies still play 3 rounds of golf a week, and I can't keep up with them any longer. So he had his knee replacement simply to keep up with his buddies. But then within 2 years, they were all dropping down to 2 rounds a week, and then 1 round a week, and then he gave it up. But it does have a big impact. And if your life has changed because of it, then that's really significant. Regardless of how much pain you've got, if it's simply that you just don't have the confidence and the ability to get out and do the things that you once did, for the fear of falling or for the fear of your ankle or your knee giving way, then actually there's a huge impact on your life, and we need to address that. And if we don't, then we're missing a very important step. Oh, this is tiny text on here, but the reason is that there's lots to go through with treatment of arthritis. So traditionally, when you come and see me and I think this is definitely osteoarthritis, and I haven't really talked about how we make that diagnosis. Most of it is actually from the history and the examination. A lot of patients will come in and say, I think it's about time I had an x-ray, doc. This joint's really hurting me. And if I'm confident this is osteoarthritis, the only reason I would be asking for an x-ray is if actually I think it's got to the point where you need surgery, because the surgeon's not going to do an operation on you unless he's got some x-rays. And it doesn't help me in any way to give you advice or to direct you, because the one thing that tells me whether you need to go up the next step on this treatment is the pain, the disability, the discomfort that you're having. And sometimes we'll do an x-ray and I'll look at your hip or your knee and go, well, it doesn't look that bad. What's all the fuss about? And that's the wrong approach to take. So we mustn't necessarily use x-rays. It's sometimes useful if there's a question as to what type of arthritis this is, because there are subtle differences between the different types. But usually if you've got an osteoarthritis and you've ticked all the boxes in the history and it all fits, then x-rays aren't too useful. But the traditional treatment has always been painkillers. Let's try and make it less painful. If they aren't working or you've hit the maximum amount of those, then we sometimes talk about steroid injections. And when those aren't working anymore, we talk about replacement. So that's the sort of traditional process that you would go through with your GP. Painkillers, that we could talk for hours on painkillers. Normally we would suggest anti-inflammatory medicines because they are very good for arthritis and for joint pains. However, there are lots of patients as you get older that can't really have anti-inflammatory medicines. There are some medical conditions that prevent them. The issue with them, if you're using them long term, is that they're not very good for your stomach. They aren't very good for your kidneys. And they do interact with your clotting and your bleeding potential. So other medicines become very relevant with anti-inflammatories. Paracetamol is the staple that we've always stuck to, and most of you will have done the sensible thing before you've come and seen the doctor and already be taking those regularly. They are of benefit to some, but not all. And then the next step would be to start much stronger painkillers. And the problem with stronger painkillers are that your body does start getting used to them. We know that if you take strong painkillers like codeine or cocodamol or dihydrocodeine or stronger medicines like tramadol, that within 3 months, actually your body's got very much used to having that medicine, and they are not as effective as they once were. So using strong painkillers intermittently when you get a flare-up is perfectly acceptable and very sensible. But if you're finding that you're using them every day, then you have started down a very slippery slope in terms of dependence upon a drug that isn't really going to serve you any favors in the future. So we have to think about other ways of managing your pain. Steroids is one. So that's an anti-inflammatory drug we can pop into the joint, and they are very effective, but not completely effective. I usually tell my patients about 60-40 in your favor of working. A common question is, well, will it come to a point where I can't have any more? I've heard that I can't have more than 3 injections. My standard response to that is you can have as many as keep working, and when they don't, we'll not use them anymore. The issue with steroids are that their efficacy diminishes as your disease progresses. They also cause some thinning in the joints as well. We know that when we put steroid creams on our skin, they make the skin thinner. Well, they do exactly the same thing in your joints. And of course, we've talked about arthritis being as a result of your cartilage becoming thin. So it's helpful for pain control. It's helpful for managing the symptoms, but ultimately they will stop working if they worked in the first place. And then you have to go and see a surgeon, potentially, which is perfectly valid and a very acceptable approach. I can see a couple of scars around the room, so that they are a useful strategy, and it's simply where the joint is mechanically no longer functioning anymore. You have significant pain that is having a very significant impact on your life, and surgery is then the most beneficial option. But it's not without its risks. Again, I can talk about my family. My father's had both his knees replaced, and he curses the day almost daily. But they really were quite awful to start with. I think he's just from Yorkshire and so likes to moan. But it's not always good, and I think you have to invest very hard and very heavily in the early stages following a joint replacement in terms of physiotherapy and activity to really get the most out of them. And if you don't, then the outcome is usually not so great. Most importantly, when we're moving away from all of the things that a doctor can do, physiotherapy and alternative therapies, chiropractors, osteopaths, are all very, very helpful. But physiotherapy, in my mind, is the one thing that you should all consider if you are developing arthritis. Even if it's just for a few sessions to get the right exercises to strengthen your joints, it's very, very important. And the reason for that is that our joints, most of them that wear out, are ball and socket joints. If you're towing a trailer and you have your ball and socket on your trailer and there isn't any grease in there, and the ball is rattling around in the socket, it's going to wear out pretty quickly. So we need to make sure that the two surfaces are in contact with each other and aren't wobbling around too much. And that comes from the muscles and ligaments that surround and support our joints. Our joints are quite easy. We can dislocate, easy to move around. We can dislocate them. We can waggle them. It's very obvious how much our fingers can change direction, and we can twist your hips and knees in all sorts of directions. But the stronger they are held in position, the stronger they will be and the less they will wear. So it's often a paradox. You'll say, well, why are you telling me to keep active when I've got arthritis? Because it's the activity that's caused the arthritis. But actually, it's about the strength around your joints that makes the biggest difference. And if you can keep the strength around your joints, then you will preserve their use for much longer. The other thing is that just like our muscles, if we go to the gym every day, we get stronger. We see our muscles grow. Our cartilage is exactly the same. If we exercise our cartilage, it becomes more healthy. It develops more. It's stimulated to grow. Of course, if we overdo it, then we can damage it. Just like going to the gym and lifting something too heavy, we can tear a muscle, we can put ourselves back a long way. But activity is so important for stimulating our cartilage as well as strengthening our muscles around joints. So physiotherapy is really, really important. The other thing I put on there are aids and devices. So stability is really important, and sometimes through no fault of your own or through accident or injury, you've got instability in a joint, and sometimes it's very important to add to that stability. You've all seen people with knee braces or wrist braces and splints, and that can be very helpful as well, particularly when certain activities are stopping you doing something. By using a splint or a brace, that can increase the use that you have out of that joint and that limb. Lifestyle. This is something you do completely outside of the doctor's room or the physiotherapist's clinic. Lifestyle makes a massive, massive difference. We're going to get a little bit technical in terms of mechanics, but just focusing on the knee, weight has a big importance. If we're carrying more weight, we're putting more force through our joints. And whilst we're walking, our weight is multiplied by 1.5. So if we weigh 100 kilos, then actually we are putting 150 kilos through our knee joint every time we put a foot down, which is quite a lot. If we go upstairs where our knee is bent sort of 45 degrees, we're actually increasing the force through our knees by 2 to 3 times. And if we bend our knees beyond 90 degrees to pick something up off the floor, then actually it's 4 to 5 times our weight. So the simple process of a 100-kilo man bending down to pick something up off the floor means that it's equivalent to him putting 400 or 500 kilos down through that joint, which is vast. So if you think about it in those terms, if you just lost 5 kilograms and you're going up a flight of stairs, that's the equivalent of 10 to 15 kilos reduced force through your joint. And that's a massive, massive difference to the amount that you wear. So weight is a very important factor for anyone that is overweight. It is as effective as most of the drugs I've talked about. Exercise is as effective as, if you put them side by side in a study, as taking anti-inflammatory medicines. For some, I mean, not for everyone. And what's worrying is when we look at lifestyle medicine and the research, only about 10% of people with arthritis do the recommended 150 minutes a week of exercise or more. Only 10% of those with arthritis do. Unfortunately, over 50% do less than 10 minutes in total in a week, which is where there is a real problem. So increasing your exercise is very, very important. And if you can do just half an hour, 3 to 4 times a week, that's more than most, and will certainly serve your joints very well. It has been shown, although it's quite variable, that by exercising regularly and taking all of these lifestyle changes into effect, we can reduce the progression of osteoarthritis by between 22 and 80%. So that's huge. And that's really where medicines and what I put into your knee makes no difference at all. It's about what you can do to influence the condition. The exercise should be strength and balance based. So I've already talked about the reasons why that is, to improve stability and keep the joints in good opposition. And I've already said you should be doing it at least 3 times, but at least twice a week. Just depends how much time you can give to it. And right at the bottom, I put alternatives, so new, novel things, because we're always in search of the holy grail of arthritis. About 15, 20 years ago, we thought it was a drug called hyaluronic acid, or hyaluronate, which is a bit like the synovial fluid that you have in your joints. We figured if we pump that into the joints, it would keep them going for longer. The problem is our body sees it as a protein, as if we've digested it, and consumes it quite quickly. So it doesn't last very long. There are more novel approaches looking at whether stem cells make a difference and whether we can try and stimulate the cartilage to regenerate and grow. There are some surgeons that do something called microfracturing or drilling into the cartilage to try and stimulate that regeneration. My personal opinion is that if a surgeon's going in, well, the damage has already been done, because anything that a man does is always going to, or a lady for that matter, is always going to cause scarring and damage. And I would always dissuade anyone from having a surgical intervention as much as possible until it's absolutely necessary. But for some, it's important. And sort of newer treatments, there's a process called platelet-rich plasma injections where you have a reasonable amount of blood drawn from your vein. It goes through a special machine which pulls out all the bits that are thought to be very helpful for your joints, and then it's injected back into yourself. So we take out some blood, we strip out the bits that are really helpful, and we put it back into your joint. And there's mounting evidence that that's effective. It's still not a major mainstream treatment, but it is done and it is used. And we have a therapist here tonight who's actually doing it in the clinic rooms, and he might be available afterwards for some questions if you have any. So that's trying to rattle through osteoarthritis as quick as I could. I've talked for far too long and we haven't had any questions, and really that's the most important part, I think, of tonight, or the reason why most of you are here. Has anyone got anything they would like to ask, or any specific questions?
3 replacements, 2 knees and a hip. What you said about the weight's correct. I've lost 5.5 stone, but it was a chicken and egg situation. My first knee replacement didn't work. For 12 years I couldn't walk. 4 years ago I had it redone, and luckily enough the surgeon got it right. But I had to lose the weight for it to get on, but it's still, well, both of them are still very, very stiff.
I think you're quite right about the chicken or egg, and it's a very common scenario. The less you can do, the more your weight gains, the more withdrawn you become, the less active you are. It is a bit of a vicious cycle, unfortunately. And there's no easy way around that. Sometimes you have to focus very much harder on your diet rather than activity to try and lose that weight. Once you've got that function, then great. But it's also, that's the advantage of the physiotherapist, is going to see them and finding out what you can do and what works best for you. There are alternatives, not just getting out and walking, but perhaps hydrotherapy or aqua aerobics, where the weight effect on your joints is significantly reduced, but you still get a lot of the strength gains from that.
I do water aerobics every day. It's really, really made a difference, big difference. Water aerobics every day, and it's helped me to get on and get on. I couldn't walk probably 30 yards, where now I can walk around the golf course 3 times a week. So it's made a big, big difference.
Well, I think that's some sensible advice there. Any other questions? I stunned you into silence. Fine. Okay. We'll try and just scoot through a few of the other topics before I let Mary talk to you about the inflammatory arthritis. Gout is another, in my mind, probably the second most common thing that I see patients for after osteoarthritis. It affects 1 in 14 men, and it can happen any time after puberty. And it affects 1 in 35 women, and it tends to happen more after the menopause in ladies. The science bit, it's caused by uric acid forming crystals in our body, and they form crystals in our joints. Uric acid's produced as a breakdown product from a protein type called purines. So they're incredibly common. They're in a lot of foods that we eat. But if we have too much uric acid, just like those science experiments at school where we can grow crystals in a concentrated solution, the crystals start to form. And it's those little tiny needles that form in our joints that are incredibly painful and create those sort of classic red hot swollen joints. The textbooks always talk about the big toes, but they can affect any joint. So foods are a reason. Yes, there are genetic reasons. Some of us don't have enough of the enzyme to break down the uric acid, and that's the minority of people that present with gout. The majority of patients tend to have either dietary causes or other reasons, sometimes medicines, stress, reasons that they're breaking down protein, other illnesses that mean that they're destroying lots of muscle or breaking down these proteins quicker than normal, or their kidneys aren't working quite as well and the concentrations are building up. But the most important thing is to try and reduce the amount of these purines in your diet. So I've kind of put a list here of foods that are low in purines, right the way through to foods that are high in purines. Dairy, eggs, cereals, fruit, veg are all good, apart from in the brackets, which are asparagus, cauliflower, and spinach. They tend to have a lot of purines in them. We then move on to the things that we'd normally recognize as being high in protein. So your meats, your poultry, your beans, your mushrooms, and your whole grains. And I don't want you to cut those out. It's just moderate those. And the bottom line, offal, game, oily fish, seafood, malt extracts are the things that you should really try and cut out. Now, of course, oily fish and seafood are really important for other reasons as well. So it's about getting a balance. And the issue with a diet is it's very individual. We all have things that we like and don't like. But if you look at that list and go, I've got gout and God, I love my liver, or I really like my Bovril, then you probably need to rethink what your favourites are. Again, another very useful resource if you have got gout is the UK Gout Society, and their website is ukgoutsociety.org. Lots of information about how you can treat it and what you can do. Gout, if you get it frequently, should be treated. And if you get it infrequently, we should certainly be checking your uric acid levels, because if you keep getting these crystals in your joints, well, as you can imagine, if you've got needles floating around in a perfectly smooth surface, they're going to damage it. And so our aim really is to reduce your uric acid levels to a pretty low level, or certainly keep it low. And so if you do have regular gout, then you should definitely be on treatment. And if you don't, but have intermittent episodes of gout, then you should certainly have that discussion with your GP and definitely have your uric acid level checked at least annually, but certainly up to treatment. And I'll let Mary chip in on there because she'll definitely know more about it than I do.
I was going to say the big thing not to forget is alcohol. Alcohol makes a big difference, and conventionally it always used to be always beer, but it's actually any alcohol, beer, wine or spirit. And I've certainly seen people with really bad gout and just managing to knock the alcohol on the head has got rid of their gout without the need for treatment. So that's certainly something I would mention. There's something to be aware of. And conversely, I've also seen people who haven't been compliant and literally have been coming to the department every time they've been to a wedding or had a big, or there's bank holiday, seems to coincide with bank holiday, they've had a bit too much to drink and they get a bad attack of gout. So it's another thing, just, you know, talking about helping yourself and things you can do to help yourself. That's another thing to think about. And again, I'd agree with Dr. Denton about urate lowering therapy. It's certainly something to consider if you're getting bad attacks of gout or frequent attacks of gout. And the idea really is to reduce those uric acid levels in your blood so they're less likely to precipitate into your joints. You just like to get this crystal in the joint and get the inflammatory response that's associated with gout.
So the reason why it's alcohol in all alcohols is really related to what alcohol does to your system. We all know that you can get a banging hangover in the morning if you've drunk too much, and that's part because you're dehydrated. Alcohol has an impact on your kidneys, and essentially what happens is your urate levels go up. Your uric acid levels increase when you've been drinking. So hydration is the other side to this, which is definitely drink lots. We should at least, in a cool day where we haven't been doing any activity and it hasn't been nice and warm like today, be drinking at least 1.5 litres. So that's at least 3 pints of clear fluids. And on a hot day, more than that, 2.5 litres. And if you're a big chap, then probably 3 litres. So hydration is very important because the more we can flush out, the better. So that's gout.
Would you include cups of tea in that hydration process?
I would happily include cups of tea in that hydration process, apart from the caffeine. So caffeine, again, as we know, helps us go to the loo. And it's really trying to avoid the dehydration side of things. But yes, the amount of caffeine in a cup of tea, if you're drinking 10 cups a day, then I'd be happy with that rather than you not. My grandmother often says there's enough water in wine to keep her going just fine, but I would argue against that, particularly if you have gout, and certainly trying to stick an extra pint of water in there or just something that's fairly clear will definitely make a big difference. Does anyone have gout here?
I went to the doctor about a month ago with a swollen ankle, and she suspected gout. I went away on the Saturday, and on the Sunday my wrist started swelling up really badly. I couldn't use my hand at all. I'd gone to a doctor down in Wales, and he gave me some medication which I took for 2 days, which had a very bad effect on me, a really bad effect. I mean, I could feel my heart pounding away, and I couldn't bear any clothes on me. So hopefully I haven't got gout.
Well, have you had any blood tests?
I had some about 3 months ago, and it was A-OK then. Everything was A-OK because I suffer with a Palpitations.
Okay. Fine. It can present, as I say, in any joint, and certainly if you've had it in more than one at the same time, Mary, this is why Mary's got a big smile on her face here, because it might not be, and that's really perfect introduction to this slide that we've got here. And I'll hand over now really to Mary, who's hopefully going to do the rest of the talking.
Well, heading back to gout, about 70% of cases are in your big toe. But that obviously means that 30% of cases can be anywhere and can be in more than one joint. So just because it's more than one joint doesn't exclude gout, or perhaps pseudo-gout. But that's probably a slightly different topic. Heading on to inflammatory arthritis, because I guess as a rheumatologist, this is our bread and butter. This is what we deal with day to day. And we're really interested in seeing patients with inflammatory arthritis as soon as possible when they develop symptoms. And there's been big public health campaigns into this. So there was the 3S campaign that was run by NRES. I think these posters first started making an appearance in GP surgeries and in outpatient departments back in about 2011, 2012. And it's really focusing on some of the things that were mentioned earlier. So the stiffness in the morning that's lasting over 30 minutes to an hour, rather than the stiffness due to osteoarthritis, the swelling where you've got that puffiness around the joint, and also the squeeze. So very sensitive test for inflammatory arthritis. The squeezing across people's knuckles is often quite tender. There are obviously other reasons for this, but this is a common cause of it. So it's really important. The reason we have public health campaigns like this and we do events like this is really to highlight the importance of inflammatory arthritis, particularly rheumatoid arthritis, because that's probably one of the commoner ones, so that people are aware of the symptoms to look out for and can seek help quickly. And there's certainly a big campaign at the moment liaising with GPs. There's been quite a lot of work done about referring patients quickly and having rapid access pathways, so that if you do have a suspected inflammatory arthritis, your referral comes quite quickly. So within, they say, about 3 working days, it should be with ourselves, and we should be aiming to see in the rheumatology department within a few weeks of that to try and get the ball rolling. Because as we touched on an earlier slide, the earlier we can get treatment in, the better the long-term outcomes are for patients, and the less disability and depression that are associated with that.
The new NICE guidance says that as GPs, we shouldn't delay in making an urgent referral if we suspect rheumatoid arthritis. So the second that you come in, if the GP is thinking this is rheumatoid arthritis, the referral should go. We shouldn't be waiting for blood tests. We shouldn't be waiting for x-rays. The referral should already be in the pipeline. There's no harm in us giving you those requests and having those done at the same time, but the referrals should be going out at the same time, and that's the latest NICE guidance. Yes,
so they're the recent guidelines from July 2018, and it's also currently being audited as well. So there's a national audit going on nationwide with the British Society of Rheumatologists auditing how good GPs are at doing the referrals, and also how good we are as rheumatologists at identifying those referrals and getting patients seen promptly and started on the correct treatment promptly. So there's certainly work. It's a big public health campaign. There's a lot of work going into making sure we've got that streamlined approach, both in primary care and secondary care. So just a little bit on rheumatoid arthritis. It's essentially an autoimmune disease characterised by inflamed joints. So your immune system generally is there to fight off infections. We all have to have an immune system that fights off infections. For reasons that aren't entirely clear, this immune system turns against itself and starts causing inflammation, causing problems in the joints. This is less common than osteoarthritis, as you can probably gather by my stats. So it's about 1% of the population is estimated to be affected. And that equates to about just under 500,000, so about 400,000 people in the UK overall are affected by rheumatoid arthritis. It is, like a lot of autoimmune conditions, commoner in women than in men, so about 2 to 3 times commoner in women than men. And it can affect any age group. I think that's a really important point to make. So certainly over at the Children's Hospital, they'll have young children, juvenile arthritis, certainly did some work there as a registrar. 2-year-olds will be seen. I'm seeing 2-year-olds in the clinic with inflammatory arthritis. And on the other side of the coin, I've also seen ladies and gentlemen in their 80s and 90s being diagnosed with this. And it's really important to tease out what is inflammatory arthritis that needs you to come and see a rheumatologist and start immunosuppression versus what is osteoarthritis, the wear and tear arthritis that was covered earlier in the evening. Because the treatment approaches, although there's some commonality, so things like physiotherapy would be recommending either way, but there is a slightly different treatment approach to manage inflammation to reduce long-term damage as a result. So again, you're never too old and never too young to develop inflammatory arthritis, I guess, is the go home point from this. So moving on to psoriatic arthritis. So again, this is an inflammatory arthritis. Again, it's your immune system, causes inflammation in the lining of the joints. It's associated with psoriasis. So you don't have to have psoriasis yourself, interestingly. It's either yourself or a first-degree relative, so a parent or a sibling, if they've got a good history of psoriasis and you've got a particular type of inflammation. Interestingly, there are case reports, so there are very small numbers in the literature where sometimes you get this arthritis. It's very characteristic in terms of what joints it affects. Before you get skin psoriasis, some people who develop skin psoriasis even up to 20 years after they first develop the arthritis. But this is very rare. This is very small print. In the majority of cases, you tend to have psoriasis and then develop the arthritis. So it's estimated to affect about 1 in every 10 people with skin psoriasis will go on to develop an inflammatory arthritis. And there certainly have been campaigns from the dermatologist point of view when they're seeing patients with skin psoriasis, they're quite alert to could they also have a co-existing inflammatory arthritis, and would have a low threshold referring patients to ourselves. Tends to be equal. So unlike a lot of autoimmune diseases, it's equal in both males and female patients. Other symptoms, so it's one of those, it has what we call extra-articular. So by that, it's just a posh medical word for saying that it doesn't just affect the joint itself, as you remember in the picture we initially saw at the beginning of the evening. It can affect other structures. So it can cause something called dactylitis, which I don't know if you can appreciate here, is what we call a sausage toe in layman terms. And essentially what that means is you've got inflammation in the joint itself and in the tendons that run alongside the joint. And as a result, you get a sausage-like finger or toe. It can also cause problems with inflammation around the tendon. So obviously there's a lot of reasons why you can get problems with your tendons. So you can get wear and tear of your tendons, which kind of goes normal part of aging as a result of injury. And you can also get it secondary to inflammation conditions like psoriatic arthritis. It can also cause red inflamed eyes, as well as something called iritis as well. It can also cause inflammation in your lower back as well. So again, back pain is a really common thing. And I know we haven't touched on back pain because that would be a talk in itself. So we can't go into all the details, but essentially it's a bit similar to with the peripheral joints, so the other joints in the bodies. When you're seeing your doctor, what's going through the doctor's mind is what is inflammatory, what is mechanical due to possible wear and tear or injury, and could there be both? So is there one, both, or the other? Because again, the reason for trying to tease out what's going on is that means we can address our advice appropriately. So we can address what's inflammatory, what might be due to wear and tear, and advise accordingly. So I put a general slide on treatment of inflammatory arthritis because obviously there are some differences, but broadly speaking, this is what we would advise. So again, I agree with Dr. Denton. Again, education is very important. Knowledge is power. The more you can find out about things, the more you understand your disease, the better it is for you. So again, Arthritis Research UK, as I hinted before, I think they do excellent patient resources. They're really helpful. They're written in easy to understand terms. They're written by medical professionals, and they're excellent resource, and they're freely available online to anybody. Just literally type Arthritis Research into Google, and they've got all sorts of information leaflets about medical conditions, about drugs, about things you can do to help yourself, about diet, exercise, working with arthritis. So they're really, really good. And obviously, and they also support a lot of medical research that we do. So they're an excellent source of information and really helpful. Again, lifestyle changes, there's a lot of things that you can do to help yourself. So certainly for inflammatory arthritis, we know that those who smoke and have inflammatory arthritis tend to have a worse outcome than those who don't smoke. So there's a lot to be said for giving up smoking. For your general health, and especially if you have an underlying inflammatory arthritis, it has been shown that you have a worse prognosis, so you don't tend to do as well as non-smokers. And sometimes the drugs don't work as well when they've done studies looking into why some drugs suit people and they don't suit other people. So it's really, really important. Healthy weight, again, for reasons we've discussed before. I don't have the same stats on my slide, but again, it's really important. The less weight your joints carry, the less strain you put on them, and the less worn out they get. So it's really, really important. Physiotherapy, again, really, really important because it's about getting the muscles around that joint nice and strong, because that helps with pain and function in the joint itself. The stronger the muscles are, the more support they can give to the joint, and it's really helpful. If physiotherapy is difficult, as we've alluded to before, things like hydrotherapy, doing exercise in the water can also be a really good thing to do as well. It's very helpful. Occupational therapy is essentially a bit like physiotherapy, but for the hands. So the occupational therapists are fantastic. They have things like wax baths. You can have wax bath therapy. There are wax baths you can even buy at home if you've something you find helpful. They can give advice about splints, and we discussed briefly that splints can be an amazing source of help because they can help make activities that were once no longer possible. They can help facilitate that. They can give advice about gadgets and aids, because I'm sure if you look on Amazon or anything like that, there are loads of different things you can get for peeling potatoes, for all, for helping with your taps, all those kind of things. And they sound very simple things, but they make a big difference day to day. If you think how many times a day you need to turn your taps on and off, and if you're struggling to do that, if you can get taps with longer levers, things like that, it makes a huge difference. So I can't praise their work enough. We do advise keeping up to date with vaccinations, and the reason being that if you've got an inflammatory arthritis, as we touched on earlier, the inflammation is due to your immune system. So your immune system that should be fighting infections turns on itself and starts causing inflammation in the joints. So we're going to give you treatment that's going to dampen down your immune system, to dampen down the inflammation in the joints. This is why we strongly recommend you should be up to date with your vaccinations, because you will be, the advantage of depressing your immune system is that you're depressing the inflammation in the joints and reducing any future damage as a result. However, in anybody who you give immunosuppression to for whatever reason, so there's loads of other medical specialities that may give immunosuppression for various reasons, you're going to increase people's risk of infections because their immune system will be dampened down. So again, keeping up to date things like your flu vaccine, your pneumococcal vaccine is really important, just to reduce your risk of infections as much as possible. And then coming on to drugs. So essentially, broadly speaking, there are two main kind of drugs that we use to treat arthritis. So there's those that we give for symptom control, which we touched on earlier, and again, they're very similar, so anti-inflammatories and analgesics to manage the pain. However, we also give drugs for disease control, because ultimately what we want to do is to dampen down your immune system, to dampen down the inflammation in the joints, which will reduce your risk of long-term damage and deformities, in order to enable people to have as active life as possible and to carry on doing the things that they enjoy. So talking about symptom control, again, this is a very brief slide because, as we've alluded to earlier, painkillers is probably a topic in its own right. But briefly speaking, and just covering what we discussed earlier, there are analgesics known as painkillers. Simplest example is paracetamol, that's freely available over the counter and that we can all get. Stronger things like codridamol and cocodamol are often available on prescription, but we also discussed the dangers of using them daily. The purpose of those is to help manage the pain. They're not going to slow down the inflammation, not going to reduce damage. They're there just to help people feel better. The anti-inflammatory drugs, so non-steroidal anti-inflammatory drugs, to give them their full names. Again, these things like aspirin, ibuprofen, meloxicam, naproxen. The list goes on. There are many, many of these. And the idea of these, they ease pain and stiffness by reducing the inflammation. But although they're reducing inflammation, they're not going to reduce damage. So they're fine for symptom control, but they're not going to reduce the inflammation to the extent that they reduce long-term damage in people. However, as we've discussed, they do have their drawbacks. So they can affect, if you're on drugs that thin your blood, they can upset your tummy. They make the lining of your tummy a bit thinner and make it more prone to ulcers. And they can also upset people's kidneys as well. So whilst they're probably okay for short-term use to manage symptoms, it's best not to rely on them too long. And then steroids. We use a lot of steroids in rheumatology, so they're steroid tablets. We can give them in tablet forms. We can give them as an injection to give overall benefit, general benefit. We can give them in a drip. If people are very bad, we can give them directly into the joint, as we alluded to before. And this is usually tend to say to patients, a bit of a short-term fix. So happy for you to have a steroid injection example in your knee to allow you to do the physiotherapy, but the steroid isn't going to stay in your knee forever, and it doesn't always work for everybody as well. So again, they're very good as bridging therapy, just to get people better until more long-term therapy is started or their flare has settled down. And I'll just very briefly go over this slide because I realise this is a very specialist slide, and if you don't have inflammatory arthritis, it's probably not of much interest. But essentially, we have two main ways of managing it. There's our standard first-line drugs, old-fashioned disease-modifying anti-rheumatic drugs. These drugs have been around for many, many years. You've got many years of experience with them. They're usually tablet form, and they reduce the attack of the immune system, but they take a long time to work, which is often why we give steroids first, gradually wean down the steroids as these drugs take over, and they can take weeks or even up to 3 months to start working. If these drugs are ineffective, there are various national guidelines. We can introduce these biologic drugs, and these are newer drugs available in the last 10-15 years, and they're targeted to target specific immune pathways. So people have looked into what happens in inflammation, what chemicals are released, what pathways are active, how can we block them. So a bit more specific. And they are more immunosuppressive. We can use these drugs when indicated as well. And this is really just for information for completeness' sake, really, this slide. So I've just briefly covered rheumatoid and psoriatic. They're probably two of the commoner kinds of inflammatory arthritis that we see. However, this is just the tip of the iceberg. We see many other kinds of inflammatory arthritis. One of those is ankylosing spondylitis, which is inflammation in the back. So rather than mechanical back pain, it's very inflammation, usually very common at the bottom between where your hips and your spine meet, your sacroiliac joints, but it can affect other parts of your spine. Septic arthritis is one to be aware of. So that's where you get an infection in your joint from whatever reason. Sometimes we see people get infections after surgery, for example. They may have got a small injury, small break in the skin when they were gardening around their knee, and that's allowed infection in. There are many reasons why you can get an infection in your knee, but it's certainly something to be aware of because it is a medical emergency that needs admission to hospital. A reactive arthritis, this is a slightly different kettle of fish. So by this, it's usually a reaction to an infection you've had elsewhere. Most commonly, GI infections, so traveller's diarrhea. I've certainly seen people who've come back from their holidays with inflammation in their joints, and usually when you've spoken to them, they do recall having some diarrhea on holiday, having a diarrheal illness. And it can also be a result of STIs as well. So sometimes we see that, usually in a slightly younger population as well, in the younger people. If you have inflammatory bowel disease, again, I don't know if anyone here does, things like ulcerative colitis or Crohn's disease, so inflammation of the bowel. Sometimes, as a result of that, you can also get inflammation in the joints when it's active. And often the underlying treatment is to treat the inflammation in your bowel, and then that will settle down the inflammation in your joints, because that's usually the driver, is the inflammation in the bowels. And when that inflammation settles down, the inflammation in the joints will settle down as a result. But again, this is probably just the tip of the iceberg. There are many different kinds of inflammatory arthritis that we look after in rheumatology, and many other diseases, so also multi-system diseases, things like lupus and vasculitis, where it's not just the joints, it's the joints and then some, so it can be joints and kidney and skin, etc. But that's probably for another day. But just to let you know, these are the kind of things that we look after as rheumatologists, really, and that we use immunosuppression for. So I think that was everything that I wanted to say. So I've, like I said, focused slightly on a different aspect, so more on for those people who have inflammatory arthritis and the importance of treating that early and presenting early to your GP and presenting early to us for treatment. Any questions?
Are there any recommended supplements to help your joints?
Wow, that's a very good question. I think the jury's out on that a little bit. And the reason is that I think there has been some research, and I looked into this. It's been a little while since I've looked into it. There is possibly some research that supports glucosamine and Contrin. But again, these are very small studies, small numbers, difficult to reach conclusive answers. So generally, my advice tends to be a bit pragmatic in clinic. If you're taking something that's regulated from Holland & Barrett or Boots at a recommended dose, it may well do some benefit, but there isn't enough medical evidence for me to recommend it and say, I prescribe this, or I recommend you buy this. But it's very unlikely to do any harm to you as well. But just be aware of things on the internet. And I tell people to be aware of St. John's wort, because it potentially interacts with a lot of other medications that you may be prescribed by your doctor. So just be aware of that. That's probably the one I'd say, keep away from things on the internet. And I've certainly seen people who've run into problems with Chinese herbs and homeopathy sometimes.
Just what the lady said there. I've took glucosamine for 4 years, packed it up 4 years ago, never made any difference whatsoever. And the same with fish oil. I was told that was very good. I packed that up 3 years ago, no difference whatsoever. Nothing of that has ever, in my opinion, works, So.
Yeah. I think the experience that people have is very anecdotal. You'll speak to someone, if you speak to my mother, she'll swear by it. I don't take it. The medical evidence is not supported, certainly within the NHS, to prescribe, and that's been the case for sort of 10 plus years now. Certainly about 15 years ago, you could go to your GP and they'd go, oh, I know nothing else works, I'll give you some glucosamine, that'll get them out. We don't do that anymore. There's insufficient evidence. However, the issue with evidence is that it's the average. And of course, you can have just as many people that are made better by something that are made worse. And if you average it, there's no difference. So anecdotally, there are several people that say it's made a huge difference to their lives. And there are several that say it's made none. And there are a few that say it might have even made it worse. And that's the problem with science when you apply it in this sense, that because you're looking at the average response, you never know. So I certainly am not I don't have anything against someone trying different things to see what works, because it is always very individual. And sometimes you might find that by eating a certain type of tomato, your joints get better, or that's not to dismiss it, certainly not to.
I generally tend to adopt a pragmatic approach. If it's helpful, wonderful. If it doesn't work for you, then, it's obviously not for you. But
I have one problem with blood pressure. And I have had 2 aneurysms. We were living in Germany at the time.
Oh.
And they put me on Zestoretic and said, you must be on that for life. Now, having come back to the UK, 2.5 years ago, I can't have it on prescription. So, in fact, I now go to Germany and buy a year's supply. And I just wonder, I know it's due to cost. They want to give me 2 tablets that would replace the 1, which I'm not happy about. And yet I've been taking that now for 9 years and not had a problem. Especially I don't want to have any more aneurysms. And yet I can't get that tablet on the NHS. And I can't buy it. I've been to the chemist. I went to our local one where the clinic is, and I can't buy it. They've got it, but they're not allowed to sell it. Which I find out.
Well, certainly there are some medicines that just aren't available, that either aren't licensed or that you can't get hold of in the UK. But in terms of how you can then source that, there's usually an alternative or something that's similar that can be sourced. But with regards to the using, I'm assuming it's a diuretic type medicine from the name that you just given, they can often interact or certainly precipitate conditions like gout, and they can make your joints potentially worse as a result. Good.
You want me to hold it? Yeah, I've come here tonight because of my hands, which are, especially my right hand, that I can't really crunch it up too much. In the mornings, it's really quite stiff. But I wonder whether is there a big difference? Could that just be repetitive strain, because I'm on a mouse all day with that hand and a space ball pushing it around on that, and this joint here is very... So I just wonder, is there a difference between repetitive strain and arthritis that is discernible easily for me to say, this is what I've got?
A lot of it's based on your clinical history. I mean, essentially, repetitive strain tends to be more tendon injury and tends to be a lot of times people, for example, on tills tend to get just because they're doing that same movement again and again, and that often gets better with rest, whereas osteoarthritis, for example, would suggest that there's damage to the joint, and there can be damage to the joint for lots of reasons. As we get older, perhaps from, it does go to say that there are some people who do more manual jobs are more prone to osteoarthritis, but not necessarily. Obviously, we see people who have done fairly sedative jobs and have still got osteoarthritis, and people in manual jobs in their 80s and 90s who've never had a joint problem in their life. So again, it's it can be difficult to tease out. There may be a little bit of both going on, but again, that would probably need a proper assessment and
certainly
from
a GP's point of view, it would be quite easy to differentiate between the two. I say that in most cases. A repetitive strain, yes, as Mary said, is related very much to the pulleys, if you like, the tendons and the muscles, whereas an arthritis is very much focused around the joints. And most of the time you will get a restriction in the range of movement from the joint rather than from the tendon, because tendons are stretchy, so you can stretch them out. You might feel it get tighter, but if you've got restricted range of movement in your hands, then it's more likely to be related to the joints. Just as you saw in that original picture, the osteophytes build out the side, and therefore if you've got a nice curved joint that's getting flatter and wider, it's just not going to bend as much. And so you often get that mechanical jump.
My worst joints are the ones that are doing all the clicking and the pushing. And so, none of them are like I was 10 years old, but some are definitely worse than others, but those are the ones that all day long I'm doing the clicking. So does that give me hope that I'm not actually, the joints aren't completely shocked, that it's actually some tendon damage in there as well? Would you suggest, I was an instant diagnosis of 10 feet?
Well, I'll try. There is probably a combination of the two. There always is. It's never clear cut, but it sounds very much more like you're getting an arthritis in your joints rather than a repetitive strain and a ligament or muscular problem, just from your description and the issues that you're having. And because it's in those fingers that you're constantly using all the time, yes, they're sort of stiffening up and wearing out, if you like. Sorry to be the bearer of bad news.
So I'm just aggravating the condition.
But there are lots of things you can do to help that. And actually, so we didn't talk about the different ways of getting anti-inflammatory medicines. The gels, the sort of things you can put onto the skin, I always dissuade people from using on their back or their hips or their knees or their big joints, because quite simply it's just not going to penetrate enough. But certainly with your tendons and your ligaments and the smaller joints like your hands, the anti-inflammatory gels can be quite helpful. And there are lots of studies that show that the concentration of anti-inflammatory is much higher in your tendons and ligaments, which of course don't have blood supply. They don't have a blood vessel going through them. If you put the gel on the surface of them, you can get a much higher, I think it's up to 1,000 times the concentration of ibuprofen in a tendon by putting it on as a gel than if you take a tablet. So it can be really useful for superficial things. So using an anti-inflammatory gel on your hands might help with the discomfort that you're getting. It won't help the wear and tear, but it'll help with the discomfort.
And the advantage is it won't upset your tummy or your kidneys.
But it might cause a skin reaction. Any other questions from anyone at all? Well, thank you all very much for coming. The one thing I wanted to sort of sum up with regards to arthritis is that, yes, of course, you'll come to the doctor in crisis and you'll be asking for help, but there's so much more that you can do to prevent this getting worse by changing the things you do in your life, by increasing your activity and your strength, by reducing your weight. And certainly if it is starting to develop, then getting early physiotherapy to at least point you in the right direction and tell you what you should and shouldn't be doing. And Kate, who was up on one of the slides, our physiotherapist, because it's so important, we feel, that you get good early advice from a physiotherapist, has said that for anyone that books before the end of October with her for the first consultation, she will give 25% off the normal consultation fee. So if you want some really good physiotherapy advice, and there's no obligation to keep coming and seeing her, or in fact any physiotherapist, but I would encourage you to go and see any physiotherapist. And Kate's very kindly suggested that anyone that has listened to this, either here or on Solihull Radio's podcast, if they make a booking with Kate before the end of October, can get 25% off a consultation with her. Well, thank you all very much. I hope you found it helpful. And our next talk is in November. I think it's the 28th, as I'm looking over someone's about anxiety. So it's a mental health focused talk. Again, it will be on Solihull Radio, hopefully. And if any of you are struggling with mental health issues, in particular anxiety, but often associated with the depression as well, then we'd very much welcome your attendance. And if you can't, then please listen again on Solihull Radio. Thank you very much.
Thank you.